Hi everyone, I'm Dr. Roman and I'm a board certified hematologist-oncologist, and this video is on the treatment of pancreatic cancer, specifically chemotherapy, immunotherapy, and what we like to call targeted therapy. That's right, we're going to cover a lot of information, but I'll tell you what, if you are serious about learning about pancreatic cancer and the treatment about pancreatic cancer, then this is the video that you have to see. I promise you, it will be worth your while. Now, I'm going to throw a lot of information your way, so I'm going to recommend that you grab a piece of paper and a pen, because a lot of these things you may want to write down and ask your doctor, okay? So I'm going about this as if I was a patient and I am preparing myself to have this important conversation with the doctor, okay, or with your doctor. So with that being said, let's get started. All right, so a little medical disclaimer, this is for educational purposes only. So if you've been diagnosed with pancreatic cancer, chances are that you will receive chemotherapy or a chemotherapy regimen, all right? And there are many out there. For example, the most common ones used is one that's called Fulfinox, which it's a bunch of chemotherapy drugs put together and given to the patient. Another one is called Nellerox. Another one would be Gemcidabine and nab-paclitaxel. Needless to say, these are all a bunch of chemotherapy drugs that are given to you. Now, what I plan to do on this video is we will break down these regimens by individual chemotherapy drug, and you will know the unique side effects to these drugs, okay? Because if you know this, then you will understand. And then at the end, we will put all these drugs together and we will discuss the individual regimens. So for example, we will go over Fulfinox, Nellerox, Gemcidabine, nab-paclitaxel, and you will understand, okay? And I will tell you everything that I think you need to know as a patient. Now, we're also going to go over targeted therapy, okay, which we're doing more and more nowadays and is something that you really need to know about. Now, if you're interested in learning about pancreatic cancer as far as surgery, what makes it so aggressive, I mean, all those details, I suggest you find my video within my YouTube channel, and this is what the video looks like. It's called Pancreatic Cancer Explained, where I go into a lot of details. I have to tell you, as far as treatment is concerned, the most important treatment for pancreatic cancer is surgery. Okay, so that's something that you really need to know about. There's many different types of surgery depending on where your pancreatic cancer is located. For example, a Whipple surgery or a distal pancreatectomy. All of this and much more I go over in this video titled Pancreatic Cancer Explained. So I recommend that you check this video out. Okay, so let's move on. So before we get into individual chemotherapy drugs one by one, I'm going to give you what I like to call chemo clinical pearls. So these are just little details that you need to know that will improve your outcome. It'll just make your life a lot better, okay? So just know that for most of these chemotherapy regimens, you will require a port. And a port is a catheter that goes under the skin, giving the doctor good venous access to administer these drugs, because you do not want to have a peripheral vein, for example, a vein in your arm, to receive these chemotherapy drugs for multiple reasons, which you will quickly learn. So this is what a port looks like. So it's under the skin, and the nurse will access the port with a needle. It's pretty simple. It's usually an outpatient procedure. You go in, they put in the port, it's under the skin, and then when you go receive your chemotherapy, they put the needle inside the port, and when you're done with chemotherapy, they remove the port, and that's it. When you have a port, it's usually in this area here, either the upper right of your chest wall or left side of your chest wall. And overall, if with a port, you can bathe, you can still go to the beach. So it's very handy to have. So prepare yourself, because your doctor will likely recommend a port. Also, we will monitor your blood counts, because chemotherapy can decrease your immune system, your platelet count, so you will have frequent blood draws, okay? We also want to monitor your liver, your kidney function. I also have a video in my channel describing monitoring your CBC during chemotherapy. That might also be something that you may want to check out. Also, managing side effects at home. You will ask, or you should ask your doctor, what side effects are you likely to develop so that you can prepare yourself. So for example, nausea and vomiting is a big one. So your doctor will give you medications in case you have nausea and vomiting at home. You can treat that, okay, or prevent it from even happening. The other thing is proper hydration. Can't stress this enough. These chemotherapy drugs, if you're dehydrated, the side effects are worse. So I usually tell my patients, take in a lot of fluids. And a good measure is the color of your urine or the amount of urine output. So if you notice your urine is very yellow, okay, it's very concentrated, chances are you're not taking in enough fluids. The other thing is, how frequently are you urinating? Okay, if you're urinating frequently, then that's a good measure that you're taking in enough fluids. So hydration is very important. And last but not least is pain management. Now I have to tell you, if you receive chemotherapy, there's a good chance that that chemo will shrink up the tumor and will make the pain level less. It will improve your pain. But if you have a lot of pain while you're receiving chemotherapy, that will make treatment worse for you. I've noticed that patients in pain have more side effects. Okay, so by the time you start receiving chemotherapy, make sure your pain management regimen has been optimized. So make sure your oncologist either treats your pain or sends you to a pain specialist so that pain is under control as much as possible. All right? All right, so the first chemotherapy drug that we are going to go over is called 5-fluorouracil, also called 5-FU. Okay, it disrupts DNA as with all of these chemotherapy drugs. So just remember that cancer in general is rapidly dividing. Okay, so in these rapidly dividing cells, chemotherapy can damage the DNA in these cells and it can start killing off cancer cells. And that's the way that it works. All right. So 5-FU is given intravenously, and the side effects tend to be nausea and vomiting, which is not very severe for 5-FU. It can cause diarrhea. It can cause mucositis. Those are those little painful white ulcers in your mouth that are pain in the behind. And it can also lower your blood counts, okay? Like I already said, your white blood cells, your platelet counts, so your doctor will monitor you. Now, I just thought I'd throw this in here. This is not something you really need to know, and it's very rare, but there is an enzyme. It's called DPD, and if you have DPD deficiency, you can develop severe toxicity to 5-FU. Again, it's very rare, but if you receive 5-FU and you become extremely ill, you might be DPD deficient. But this is very rare. It's just something that I thought I'd throw in there. All right, so the next drug is called Lucoorin, and this is called also folinic acid. And all it does is that it helps the 5-FU work better. And that's right, folinic acid is a folic acid derivative, so it is a vitamin derivative. Lucoorin, if used by itself, is usually very well tolerated. All right? Remember, we're going over these chemotherapy drugs one by one, and then at the end, I'm going to tie it all in. So trust me, it's going to make sense to you towards the end of the video. Capcidabine is another medication commonly used. It's oral 5-FU. That's what it is. So the 5-FU in a pill. So it will have the same side effects that we already mentioned for 5-FU, but it also has a unique side effect that's called hand-foot syndrome. And you really need to know about this if you receive capecitabine, because you might develop a rash on the palms of your hands and the soles of your feet. Okay, and it can be quite difficult, and sometimes we have to reduce the dose or stop the treatment. It can become that severe. So something you need to know about. Now, what can you do to treat it? Well, any topical cream to hydrate the skin, usually containing urea, that you can buy at your local pharmacy is a good start. And also applying cool compresses. Heat tends to make the rash worse. So something that you need to keep in mind. And again, if you have DPD deficiency, you can develop severe side effects. We usually do not test for DPD because it is so rare that we usually do not test you for that, but just something that I wanted you to keep in mind. The other drug is called Oxaliplatin, okay? It's a very good drug. It interferes with DNA like they all do. It's given in the vein, and this one has a moderate risk of nausea and vomiting. It can cause diarrhea, although it's not really a major side effect. Loss of appetite. It can also lower your blood counts. Now, the major side effect that I want you to know about Oxaliplatin is neuropathy. That is the pins and needles that diabetics, for example, get on their fingers, their hands, their toes, the numbness sensation, the burning sensation in your fingers, and it can be quite severe. And there's two types of neuropathy that Oxaliplatin can give, an acute one and a chronic one. So the acute one is when they give you the medication, usually within the first 3-4 days, you can develop what we call cold sensitivity. Okay, you got to prepare yourself if you receive Oxaliplatin, because if you touch something cold, you will get, like patients have described it to me as a shocking feeling. It shocks you. Okay, so it's cold sensitivity. And also you got to be careful, because if you drink something cold, I've even had patients tell me that they had a spasm in their throat, and it can make breathing quite difficult. Again, this is not as common as you think, the actual laryngeal spasm, but something that I want you to keep in mind. So when you're receiving Oxaliplatin, be careful with touching things or drinking things that are very cold, especially during the first few days that you receive Oxaliplatin. The chronic neuropathy is when you've received Oxaliplatin for a long time, 6 months, 8 months, a year, then you can start developing those pins and needles sensation in your hands and feet, and it can become quite severe. So if you are on Oxaliplatin and you are having these pins and needles, this numbness, burning sensation, let your doctor know. All right. Now moving on. Now Irinoten is another drug. Again, another one that interferes with DNA. It's given intravenously. Nausea, vomiting, fatigue, lowering your blood counts. It's the same common theme with most chemotherapy drugs. Now, the main thing you need to know about Irinoten is diarrhea. It's very common for Irinoten to cause diarrhea. So your doctor will give you medication to help prevent the diarrhea in the first place. But you have to be ready at home. Again, you have to keep yourself hydrated, and you have to have some of that Imodium handy. Just ask the loperamide, ask your doctor how to use it, how frequently to use it to treat the diarrhea if you were to develop diarrhea. So just something that you need to keep in mind. Remember, Irinoten, diarrhea, it's a biggie. And if you're having a lot of diarrhea, you need to maintain yourself hydrated. Okay, hydration is key, because the more dehydrated you become, the more side effects you tend to have. Right? Again, you don't need to know this. I just thought I'd throw this in there for the nurses or the students or the physicians watching this video, that you may have, if you have a UGT1A1 mutation, you can develop severe side effects to Irinoten. But this is not common, okay? This is very rare. Now, there's another medication that is called Liposomesal Irinoten. So it's the same as Irinoten, but it's another formulation. It's called Liposomesal Irinoten. It's also given IV. And what happens is that the liposomal variant has a longer half-life. It lasts longer in the body. So if it remains longer in the body, it can fight off the cancer a little bit longer. Okay, and that's the principle behind liposomal Irinoten. And again, that diarrhea is something that you need to keep in mind. Gemcidabine, very good drug, commonly used, affects DNA, given intravenously. The side effects, gemcitabine in general is pretty well tolerated. Just know that it can decrease your blood counts. Now, what I do need you to know about gemcitabine is that it can cause, especially within the first few days, usually day number 1, day number 2, that you receive the drug, is that it can cause fever or a flu-like illness. You can feel like you're under the weather. You have fever, you have body aches, muscle pain. And what we usually recommend for this is acetaminophen, okay? So you usually take acetaminophen and the symptoms disappear, or they tend to dramatically improve. So something that I want you to keep in mind. And as I said, gemcitabine in general is fairly well tolerated unless you are receiving higher doses, okay? Now, there's a chemotherapy drug, and we're almost done. We're going to get into the fun part, which are the actual regimens, okay? So hang in there with me. We're almost done here. There's a drug, a chemotherapy that's called Pletaxel. Now, if we take paclitaxel and we bind it to albumin or a protein, then that's called nab-paclitaxel. The other name is Abraxane. I love this drug for pancreatic cancer, works very well, and in general, it's fairly well tolerated. So again, it affects DNA, it's given intravenously, it can cause nausea, vomiting, hair loss, alopecia is a big one. It can lower your blood count, so again, common theme with all these drugs. It can also cause neuropathy and infusion reaction, so an allergic reaction while you're receiving the drug. Now, paclitaxel by itself tends to cause a lot more infusion reactions, whereas nab-paclitaxel, once it's bound to protein, much less incidence of infusion reactions. So that's one of the main reasons I really like this medication, okay? Cisplatin is another drug. This one is not as frequently used, but I do want you to keep in mind that this is another drug, and I'll go over why I want you to know this. But again, it affects DNA, it's given intravenously, and there are three main side effects that I want you to know about cisplatin. Number one, cisplatin is very hard on the kidneys. So hydration is key. Your doctor will hydrate you big time, and while you're home, especially for the first few days, you need to take in a lot of fluids. The other thing is ototoxicity, hearing loss. So if you notice that you're getting cisplatin and you're losing your hearing, let your doctor know. Or if you are hard of hearing from the get-go, let your doctor know, because cisplatin might not be the best choice for you. And last but not least, cisplatin causes a lot of nausea and vomiting. So they will prepare you for this and give you a lot of medications to prevent the nausea and vomiting. But remember, if you are vomiting and you're not holding down fluids, we go back to the kidney toxicity, okay, the renal toxicity. So you need to take in a lot of fluids, and if you notice you're vomiting, do not wait. Let your doctor know, because you may require intravenous hydration to protect those kidneys. Okay, now, this is a very important topic that we're going to go over, and this is targeted therapy, and you need to know this. If you have pancreatic cancer, there's a good chance, especially if you have more advanced disease, that your doctor will test you genetically. Now, there's two types of genetic testing in a cancer patient. Number one is hereditary testing. So, for example, were you born with a gene that predisposes you to cancer? That's the first one. The second one is what we call somatic testing. Have you acquired or developed a genetic mutation because either you were a smoker or a drinker, or because of your age, or just because of bad luck, that that mutation that you were not born with caused the cancer, or is one of the causes of your cancer? And there are many out there. You do not need to memorize this, okay? But I want you to keep in mind that, for example, these are some of these mutations or some of these findings. So as an example, if you have a BRAF V600E mutation, then you might be a candidate for this treatment option. Or if you have an NTERT mutation, then you're also a candidate for one of these medications, and so on and so forth. So as another example, if your tumor mutational burden is greater than 10, you're a candidate for immunotherapy. Same as if you have what we call microsatellite instability, you're also a candidate for immunotherapy. So again, these are all tests that your doctor can do to tell us if you're a candidate for one of these treatment options, okay? So a question that I would ask my doctor would be, doctor, do I have one of these mutations? Am I a candidate for one of these multiple treatment options? Because if you are, then you can get that very important benefit from one of these chemotherapy agents or immunotherapy, okay? Very important. Also, in my channel, I have a video titled Genetic Testing in Cancer Patients that you may also want to check out, okay? So let's move on. Now, before we continue, we get into the chemotherapy regimens, what you really want to know, I'm going to ask you, if you're finding this educational, then guys, like, subscribe, and very importantly, share the video so that other patients can also get a benefit. And if you notice, my videos are tailored for patients, so you may also want to check out one of my other blood or cancer related videos. All right, so the first chemotherapy regimen that we are going to go over is called Fulfinox. And if you have pancreatic cancer, there's a good chance you will receive this regimen. Now, why this fancy name? Well, let me break it down for you. Now that we went through all the chemotherapy drugs one by one, you will understand it. Notice that the FOL is folinic acid, the F is 5-FU, the IRIN is irinotecan, and the OX is oxaliplatin. See, now you know what you're getting. You're getting all four of these drugs together, and that is the Fulfinox regimen, okay? It's IV combination chemotherapy given in the office, okay? So you're gonna go to your doctor's office, you're gonna sit in a chemo chair, and through your port, they're gonna give you all four of these medications. And then you will go home with a pump receiving 5-FU over 46 hours, give or take, okay? And this is an example of an elastomeric pump. There are several different pumps. You have electronic pumps, you have these plastic type pumps or rubbery type pumps. And the whole idea is that this pump will give you chemotherapy over 46 hours, and then you're gonna go back to your doctor's office and they will remove the pump and take out the needle from your port. And that's it. And then 14 days later, you will come back, okay, to receive your next treatment, which is the same thing. It repeats itself. So every 2 weeks, you will receive Fulfinox. Okay, I have to tell you, Fulfinox is no joke. Fulfinox is pretty rough. It's a very good chemotherapy. It's you have to prepare yourself for Fulfinox. And if you're a little bit older or more debilitated, then maybe Fulfinox is not the regimen for you, okay? Now, I do want to tell you, I have patients that are petrified of receiving Fulfinox. And when they receive Fulfinox, they do a lot better than they expected. So listen, do not jump the gun. Don't be negative. You might be one of these patients that tolerate chemotherapy a lot better. So I always tell patients, do not listen to your friends, because a lot of people will tell you, oh my God, chemotherapy is horrendous. And you might be pleasantly surprised. Some patients tolerate it a lot better than you'd think. Okay, so something that I want you to keep in mind. Now, there's also a Fulfinox regimen that's called modified Fulfinox regimen. And all that means is that we alter either the dose or we remove one of the treatment options. So for example, the usual modified Fulfinox is a lower dose of irinotecan, okay? So they will lower the dose so that you tend to get a lot less diarrhea, because remember, irinotecan, diarrhea, and you will not receive 5-FU in the office. Remember, 5-FU, you get it in the office and you also get it in the pump. Well, your doctor may decide to hold the 5-FU in the office portion and only give it to you in the pump. So it's a lot better tolerated. But again, when you start removing chemotherapy, it might also be a little less effective. So have that discussion with your doctor. Do they want to give you Fulfinox or modified Fulfinox? But now you know the difference. So let's move on. Now, the next treatment regimen is called Nellerox, another very good regimen that you might receive. It's similar to Fulfinox, but instead of irinotecan, you are receiving liposomal irinotecan. Remember, the one that lasts longer in the body. So you're receiving the same 4 drugs, okay, that you did in Fulfinox, but the irinotecan is liposomal. It's the same thing. It's given every 2 weeks. So you go to your doctor's office, they give you the all 4 in the office, and then you go home with the pump receiving 5-FU 2 days later, you come back, they remove the needle, and within 2 weeks, you're back in the doctor's office receiving the same treatment regimen. Now, remember, before you get all of these chemos, your doctor will perform laboratory studies to make sure that your liver, your kidneys, your white blood cells, your platelet count, that they're all acceptable in order for you to receive the chemotherapy. Because if you're, for example, if your white blood cell count is too low, they may hold chemotherapy for another week, okay? So just something I want you to know. Now, comparing Fulfinox with Nellerox, just know that Fulfinox tends to be a little more aggressive as far as lowering your blood counts. So just something to keep in mind. And Nellerox tends to cause a little more diarrhea, because remember, Nellerox has the liposomal irinotecan, which lasts longer in your body, and you already know that irinotecan causes diarrhea. So it's a no-brainer that Nellerox would cause more diarrhea. See, this is why you need to know each drug individually, because once you know this, then you can anticipate what the specific chemotherapy regimen will do, okay? Now, moving on to the next regimen that's called Gemcidabine and nab-paclitaxel. It's these two drugs given together, so it's a two-drug combination, Gemcidabine and nab-paclitaxel. I really like this regimen. It's very good. Now, this regimen is given IV. You do not need a pump for this, okay? You do not go home with a pump. And this is given on day 1, day 8, day 15, and then 28 days later, it's repeated again. So as an example, let's say you receive chemotherapy on a Monday. So that Monday you will get chemo. The following Monday you will get chemo. The following Monday you will get chemo. And then the Monday after that, you have it off. So it's day 1, you will get chemo. The next week you get chemo on that one day. Then you get chemo on the next week again. And then you have a week off. And then it repeats itself again. So day 1, day 15, every 28 days. Just know that you will get the side effects of Gemcidabine and nab-paclitaxel. You will monitor your blood counts. Remember the hair loss. Remember the Gemcidabine with the flu-like symptoms, the fever, so prepare yourself for that. But overall, another good treatment option. Okay, now I wanted to bring this to your attention. There's two other regimens that sometimes we use. One is called Fullfox, and the other one is called Fulfury. And I know what you're thinking. Based on the name, you can kind of guess what's going on here. And that's right. Fullfox is the Fulfinox, but without the irinotecan, okay? Whereas Fulfury is the Fulfinox without the Oxaliplatin, okay? So FOL is the folinic acid, okay? The Lucoorin. The F is the 5FU, and the OX is the Oxaliplatin. Now, Fulfury, FOL, the folinic acid, the F is the 5FU, and the IRI is irinotecan. These are usually used for colon cancer, but the reason I bring this up, maybe you're an older patient or you're a little weaker and we do not feel that you will tolerate the Fulfinox regimen, so we may opt to give you either Fullfox or Fulfury. So just something I thought you should know. Now, we're almost done. This is very important what I'm going to go over now, so please pay attention. Just keep in mind, surgery is the most important treatment for pancreatic cancer. Now, chemotherapy is another very important treatment option, okay? And there's different times that you can receive chemotherapy. And I want you to learn this, okay? There's a term that's called neoagivant, okay? All neoagivant means is that we will give you chemotherapy before surgery, okay? Neoadjuvant before surgery. The reason your doctor may want to give you neoadjuvant therapy is that they may want to shrink the tumor to make the surgery a little bit easier or to improve your overall outcome. That's called neoadjuvant treatment, okay? And there's a few regimens that we tend to give before surgery if that's what the surgeon or your oncologist want. The first one is Fulfinox, okay? The other one could be Gemcidabine and nab-paclitaxel, okay, another drug that they may give you. And if they genetically tested you and you have a BRCA, what we call the BRCA gene, 1 or 2, or you have the PALB-B2 mutation, they may also give you gemcitabine with cisplatin. And that's why I went over cisplatin before. Okay, so just know there are other options that your doctor may give you, but these are by far the more common neoadjuvant chemotherapy regimens. Okay, so your doctor is going to want to give you chemotherapy before surgery. Now, the next type of treatment is adjuvant therapy. Adjuvant means after surgery, okay? And the more common regimens here are Fulfinox. Once again, you may receive gemcitabine by itself with or without Capabine. Remember the oral 5FU that can give the rash in the palms and soles. Or they may recommend 5FU with Lucoorin together, those two medications, followed by chemotherapy and radiation, followed by more 5FU and Lucoorin. That's another treatment option, okay, after surgery. Another one could be gemcitabine by itself, followed by chemotherapy together with radiation, followed by more gemcitabine. So as you can see, for adjuvant, meaning after surgery, there are many different treatment options. So a question I would have is, what option am I going to receive, okay, if your doctor believes that you should receive chemotherapy. All right, now let's talk about chemotherapy in the metastatic setting. So, for example, let's say you have stage 4 disease. In other words, the cancer has spread to another area of the body, as an example, to your liver. So surgery is not an option. So your doctor will give you treatment to try to shrink that tumor, try to improve the quality of your life, because if that tumor shrinks and the amount of cancer in your body decreases, usually patients feel better. And I know what you're thinking, chemotherapy can also make you feel sick. But believe it or not, and I've seen this time and time again, a lot of times, despite the side effects of chemotherapy, okay, patients do better with chemotherapy because we're shrinking the tumor. We are prolonging your life. And some patients actually do quite well. So that's, as I told you before, do not go by other people's experiences. Everybody is unique, okay? Sometimes patients tell me they don't want chemotherapy. I tell them, you know what? Get one treatment. Give it a chance, and let's see how you do, okay? So that's something that you may also want to consider. So for metastatic disease, there are many options. Once again, Fulfinox, Nellerox, Gemcidabine with nab-paclitaxel, all the agents that I mentioned before, they are all treatment options for metastatic disease. And again, remember the biomarker, the mutation, okay? If you have a specific mutation, you might be a candidate for that particular medication. And also, we might be able, for example, if you're a candidate for immunotherapy, we can also give you chemotherapy together with immunotherapy. So something to keep in mind, and definitely ask your doctor about this, all right? All right, so that's it. I really do hope you found this useful. If you did, like, subscribe, share the video, and consider checking out some of my other cancer-related and blood disorder-related content. So all the best to you.